Belly pain, heartburn, blood in your stool, or other gastrointestinal problems, a GI doctor's services are invaluable. Digestion, absorption, and elimination of waste. GI issues. Tonight, on call with the Prairie Doc. Good evening and welcome to the 22nd season of On Call with the Prairie Doc. Medical information based on science, built on trust. I'm Dr. Kelly Evans-Hullinger, your Prairie Doc host. Tonight we will be discussing GI issues. Thank you for joining us. In the studio this evening on the campus of South Dakota State University in Brookings is Dr. Theresa Oey-Trudeau from Avera Medical Group Specialty Care, Brookings, and Dr. Zakaria from Monument Health Gastroenterology. Welcome, doctors. Thank you for joining us. Theresa, you've been on the show before. Theresa's our general surgeon who does a lot of gastroenterology in a small community, as it turns out. So explain a little bit about what you do that maybe the general public doesn't know about. Of course, you're the one that shows up in the middle of the night if someone's got appendicitis, but what do you see in clinic that has to do with GI stuff?
Oh, we see a lot of stuff in clinic. Constipation, diarrhea, anal issues as well. Incontinence is a big one that we tend to deal with, as well as itching and anything else that people have issues with their GI tract. Another one is difficulty swallowing. I saw a couple of those today. And so yes, with the general surgery, I do get a fair amount of gastroenterology too.
Yeah, especially in a smaller community where we don't have gastroenterology. You're our endoscopist and do a lot of that. So, and then Dr. Zakaria from Rapid City, thanks for joining us. Tell us a little bit about yourself, your career path, and what type of advanced endoscopy you do with your training.
Yeah, thank you for having me. This is a great opportunity. So yeah, I initially came from Jordan and I did my medical school there, and then I moved to the state and to Michigan in 2015. I did my internal medicine training, and then I did general GI training, and then I did an interventional year at Tampa, University of South Florida Moffitt Cancer Center. And that is an extra year of interventional training where you do extra training for high-risk procedures such as endoscopic ultrasound, ERCP, sampling and biopsies, and multiple other high-risk procedures or minimally invasive procedures we kind of call them. And then I moved to Rapid City and I'm establishing a gastroenterology practice at Monument Health currently.
Yeah, great. So some of the things that you talked about are things that not even every gastroenterologist is able to do. So things like evaluating of masses in difficult places like the pancreas and the esophagus, right? So can you talk about that? How has that changed how patients can get that kind of care?
Yeah, this is actually very promising field now. It has been going for a long period of time, but it's getting more advanced and advanced. And especially when we're connecting the oncology or the cancer with the gastroenterology. I mean, we are the biggest asset for any cancer center in terms of providing them with a proper staging, proper diagnosis, extra tissue sample for genetic testing and molecular kind of testing to get targeted therapy for special cancers or different kind of cancers. So here we have our cancer care institution at Monument Health, and the partner between us and them had made their life and the patient's service much better. Because there is anything within the gastrointestinal tract or even alongside the tract of the gastrointestinal system. For example, patient comes in sometimes with lymph nodes in the mediastinum or around the esophagus, or masses in the abdomen outside the GI tract, and I still can get a sample for them, give them accurate diagnosis. They send it to pathology. The pathology will evaluate that even more and get them an accurate diagnosis, and they can run special tests, staining, and that will give them, an opportunity to give targeted therapy for a particular diagnosis. And that's where actually the oncology is heading now.
Yeah, great, wonderful. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about GI issues. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but please provide contact information when you submit your question. All right, so I guess we'll get to some viewer questions and just see where that takes us here. We got a question from email. Oh, this is a good question. Can strong antibiotics meant to treat H. pylori cause Crohn's disease? Not one I've heard. I guess, Ali, I'll let you take that one. I guess let's talk about first, like, what's H. pylori? Why are we giving antibiotics? And then maybe we can talk about any problems with that.
Yeah, H. pylori is a type of bacterial infection that can affect the stomach. It lives in this acidic environment and can cause inflammation or irritation in the stomach. And it actually became more famous lately because there's a lot of studies that show that H. pylori is a carcinogen. So meaning that it increased the risk of gastric cancer. And that's where we got more attention to treat it and actually eradicate it.
Yeah.
The problem with the H. pylori is that it's such a resistant bacteria, and the success rate in eradicating H. pylori is 85%. It depends on the medication that we use and the algorithm that we follow. So physicians in general, when they get suspicion that the patient come in with presentation of, dyspepsia or not feeling well on his stomach, they do an endoscopy, they find an irritation in the stomach, or we call it gastritis. We take a biopsy or we do a stool antigen test, and that will tell us if the patient has this bacterial infection. The next step is to be very meticulous about how you approach treating that. And the most important thing is to try eradicating it from the first approach, from the first step. So we ask if the patient had ever exposed to certain antibiotics, and if yes, then we will pick and choose different kind of regimen. And now there's a triple therapy, there's quadruple therapy. It's multiple pills, multiple medications. Some of them antibiotics, some of them acid suppression medication. And when we give them for a long period of time, almost like 2 weeks. We used to give it for 10 days. Now I favor higher doses for 14 days to be more successful in eradicating the bacteria. The most important thing is that once you get treated for it, we recommend that you have a follow-up test to confirm eradication.
Right.
But that's the whole purpose, is to make sure that we actually treated the bacteria. A lot of patients, they don't follow up. They don't get the test to complete eradication, confirmation of the eradication. And they might have symptoms again, and they would assume that, oh, I had the infection again. Maybe, but maybe you haven't even cleared the infection.
Sure. And the emailer did ask about if there's a link between treatment of H. pylori and Crohn's disease. I've not ever heard that. Are you aware of any link?
No, I'm not. I think there is a link. There's a lot of, theories about patients who take antibiotics where they change their microbiome.
Sure.
And this is the new thing as well that we have been focusing a lot of our research and study to link the microbiome and autoimmune diseases. We found, we know that Crohn's or inflammatory bowel disease a little bit more common on, advanced or developed countries because of, the lack of exposure of certain, pathogens early in life. And that is the theory where it comes that when you get a lot of antibiotics, maybe you will get change in the flora that would increase your risk of autoimmune disease. Okay. But is there a direct link between treating H. pylori and Crohn's disease development? I do not think so.
Yeah, good. We do have a segment later about microbiome science too to follow that up. Theresa, I got a question for you. We had an emailer saying, I take omeprazole once a day. How long can I take this medicine for my GI issues? And can I also take other medicines like Tums if I get symptoms that day? So this is a commonly used medicine.
It is.
Yeah.
Omeprazole is very commonly used, even over the counter, and so patients can basically take it of their own free will. We do like to do as short of a course of omeprazole as possible, just to not suppress the acid for long periods of time. But there are some people who do unfortunately need it for longer periods of time. And so it really tends to be based on their symptoms, but we try to get them to as low of a dose as possible.
Yeah. Yeah. So, there was a study that came out that I still get asked about all the time about a link between this type of medicine and Alzheimer's, which we think is probably been debunked, like not a well done article. But at the same time, I felt like it was a good reminder to say, if we can get people off of these, we should. Sometimes we do start medicines, are not good at stopping them.
Right.
Yeah. Would you agree, Ollie?
Yeah, I absolutely agree. I think PPI is the most medication that has been recently attacked with all of the studies to kind of see what kind of side effect, because it's commonly used. It's a great medication. It works. It has a pretty safe side effect profile in general. But still, I say that if you really need it, you need it. If you don't need it, you should not keep it.
Right.
We used to have that practice in the hospital where everyone goes home on PPI for prophylaxis. I'm a kind of skeptical about sending someone on a prophylactic. There is an indication for a medication, and you should talk to the doctor. What is the indication for me to be on a PPI? And when you become someone who will need acid suppression medication for a long period of time, then what are options that you have? Do you have other options? Do you have a surgical or endoscopic intervention that can help you so you can stop the medication? And we have a lot of those. So
right. And I would say, can you take a Tums? Yes, absolutely. But I always tell my patients, if you're having to do that every day, I want to know, because maybe we need to revisit this, right? Okay, good. There's a couple questions that we'll maybe tackle at once about C. diff. So we had one emailer who talked about having C. diff twice this year. How can it happen? And then another caller asked about new and developing treatments for C. diff. So gosh, we're getting the hard antibiotic questions right off the bat, aren't we? This is another bugger to treat. So Ollie, why don't you take this to start? What's C. diff? Why is it so hard to treat?
So C. diff, again, is one of those other infections that is very important for the healthcare system in general, especially hospitals and admissions, and because it affects mostly elderly, mostly hospitalized patients. It comes in and it's difficult to treat as well. It can form spore, where you actually can be a carrier for the disease or carrier for the bacteria, but you're not actually having an infection. And the most important thing for patients and physicians or treating providers is to understand that you might have the bacteria in your body, but it's not causing any problems.
Right.
So having a bacteria or a test positive doesn't mean that you truly have C. diff infection or active infection. So differentiating between those two entities is very important. When you have the spore or the bacteria that is producing the toxin and you are symptomatic, meaning that you have a lot of diarrhea, abdominal pain, maybe bleeding, fever, severe abdominal distension, sometimes can get to a major complication. We call it toxic megacolon, where you might need surgery even to remove your colon. So that's the spectrum of this infection when it happens, from a carrier status to a need for emergent surgery. It usually happens in someone who's immunocompromised, who required antibiotics for another reason to treat an infection or bacteremia. And then when it develops, it becomes very challenging to treat, because still you need antibiotics. And sometimes the spore form of the bacteria become difficult to eradicate. We have multiple treatment options, and the multiple societies had put excellent guidelines, and they update it frequently because it's a major health care problem that has a lot of cost to our health system, and we need to be on top of it. So the guidelines pretty clear. It will guide the general provider, the internist, the hospitalist, the gastroenterologist, even the infectious disease providers, that, okay, if this is the first infection, mild to moderate, moderate to severe, how you can treat it. If the patient gets a recurrent infection or relapse, there is a difference between a relapse and recurrent infection. And then you treat it accordingly. And if they have a third infection, then that's when become more intense how we can approach it. And there is this new entity that we call it fecal microbiota transplant, where you actually get a healthy stool from another patient or a donor or a bank, and then you install that in the colon of a patient with recurrent C. diff. And we have seen excellent results in terms of treatment and response.
Yeah. And so relapse and recurrence are actually kind of common, so that's not surprising, right? Like what's cure rate with a first course of vancomycin? It's probably along the lines of H. pylori. Yeah, but there's a lot of people who don't get cured right away. It's interesting. Fecal transplant, we learn all this and we know that it's very effective. I found that my patients who have maybe met criteria, it's really hard to access in our part of the world, though.
Yeah.
You have to go to a special center for it, right? Have you had that experience, Teresa?
I have not had to, luckily, treat somebody with a fecal transplant. So, but I do know that it is difficult for them to get. To find donors sometimes is difficult. I know that I had one patient who had talked about their family was looking to donate, and but it can be difficult.
Yeah, there's it's not quite as practically easy as we would like it to be sometimes. So we'll do one more quick question before we move on to our first roll in. We had a caller ask, is gastritis chronic or will it heal itself over time? So that's another common condition that you might see on an endoscopy. Teresa, what's gastritis, what causes it, and what do we do about it?
So gastritis is inflammation in the lining of the stomach. There can be chronic gastritis, and to some degree, a lot of people do have that. But whether they're symptomatic or not is what makes a difference. And so even though you have chronic gastritis doesn't mean that we necessarily need to treat it. Now there are varying degrees of it as well, and so once we get to like a chronic atrophic gastritis, which even appears a little bit different, it appears different on endoscopy, then there is the increased risk for gastric cancers with that as well. So it gets followed differently and treated differently.
And treatment is those omeprazole type medicines like we talked about, right? Okay, great. Our gut and intestines hold billions of bacteria, many of which help protect us from viruses and other pathogens. Prairie Doc reporter Sam Schauer talked with an SDSU microbiome researcher about the importance of our gut microbiomes as well as what they do for everyone.
Rodney Kaushik is a professor at SDSU who studies the intestine and gut microbiomes.
So microbiome is basically a collective name given to all the bacteria, viruses, fungi which are normally present in the intestine, and their major role is to provide protection against different pathogens and to provide protection.
Professor Kaushik says the microbiomes hold trillions of bacteria, but not all of them protect the gut and intestines. His work includes finding bacteria that do protect, and those findings have produced probiotics for various diseases.
We can identify certain microbiome which can provide protection on Salmonella, Shigella. So we are working on different bacterial pathogens and how we can use the microbiome, set of microbiome to protect against these infectious diseases.
How Professor Kaushik obtains microbiomes is through feces sent to him, where he then creates a library for these microbiomes.
We ask people to donate the feces, we process them, and then we make sure that we are identifying specific type of bacteria. We develop a culture system where we can separate them out and then can grow them individual bacterial species, and then that way we create a set of library.
He also says the microbiomes are being studied intensively as new research is coming out that they play a larger role than most people think.
A lot of studies are coming out from different labs which shows that intestinal microbiome actually play a very important role in allergies, in even depression, some of the diseases related to brain. So they have far more effects than only restricted to the intestinal tract.
Overall, the probiotics that people get from doctors come from the hard work of researchers like Professor Kaushik.
The type of work we do is very, very important for developing new therapeutics and preventive measures for the enteric disease.
Great segment. So much research on microbiome and its links to other parts of our health that I think we'll know a lot more in 10 or 20 years. But we have a lot of caller questions, so we're going to do a round that we'll try to answer these as quick as we can and get through as many questions as we can, guys. All right? So let's see. We've got a caller from Rapid City, Teresa, who's wondering if magnesium supplements are good for digestion, and if so, what form is best. So there's a lot of magnesium products, so what might they be talking about?
So Magnesium, it comes in multiple different forms. Probably the most widely available form is magnesium oxide.
Right.
If you just go to Walmart and buy one, that's probably what you're getting. And how it probably is linked to more of digestive health is that it actually causes you to have more bowel movements. And so if you're irregular or if you're more constipated, you could become more regular with using magnesium oxide. It is a mineral that's needed in our body anyway, but the magnesium oxide form doesn't get absorbed as well as other magnesium forms like glycinate or not necessarily citrate, that is more along the oxide type.
Right. Yeah,
So.
that's a question. If patients come to me with a new complaint of frequent stools or more diarrhea, first order of business is, what are you taking that I don't know about? Because magnesium's a common offender that way. Good. Okay, Ali, we had a 60-year-old woman who has endometrial cancer 2 years ago, stage 1A, she was specific. She had a recent PET CT scan, and the doctor said, my whole intestinal tract glowed, indicating inflammation. What does that mean?
So it depends on the type. We've seen this in patients who get endometrial or gynecological cancer who get treated with chemoradiation. I'm not sure how she was treated, but if she got treated with radiation, there's an entity we call it post-radiation enteritis or gastroenteritis or enteritis in particular in her case if the small bowel is lightened up. And that is basically the effect of radiation on the small bowel. The most common form that we see is actually radiation proctitis in males who get prostate issues and they get radiation, they get bleeding per rectum or pain in that area because of the changes in the mucosa of the rectum. In her case, I think it's most likely that's what it is. If she got particular radiation therapy to that area. If she hadn't got radiation, then she might need further evaluation of what could potentially that be. Is there something else going on? Does she have PET scan is basically an image that takes glucose to a hyperactive area. So this area is active, is either because of inflammation, maybe she has another reason for that to happen.
Maybe not related to her cancer. Sure. Okay. Theresa, we had an emailer ask, are results obtained from, I'm going to say, home colon cancer screening kits reliable?
So they're better than nothing.
Yeah.
But there still is false positives and there are also false negatives. And so it is to be used with caution in terms of if you're having symptoms, this is not a proper testing for you. If you have an increased risk for colon cancer, you also should not be using them.
Yeah, really for average risk people.
Correct.
And should know what those differences are. Good. Ali, we had an emailer. This is a good complicated question. I had a Whipple procedure about 10 years ago based on the recommendation from surgeons to remove a cyst from the head of my pancreas. I now experience brief episodes of sharp pain in my upper abdomen below my rib cage that goes away after about 30 seconds. Could that be related to his prior Whipple, and should the patient be concerned? What would you say to this patient?
Yes, Whipple procedure is one of the biggest abdominal surgeries that they remove the head of the pancreas along. It depends on the type of the Whipple procedure the patient underwent. There is like a pyloric preserving Whipple where they leave the stomach as it is. But in general, it entails taking part of the duodenum, the head of the pancreas, the bile duct, and that blood supply and innervation of that area. And there will be reconnection of the bile duct into that area. Sometimes people will have anastomotic stricture, or adhesions, or if they remove the gallbladder, maybe they have some biliary pain, maybe she has some intrabiliary pathology. So yeah, it could be related to post-Whipple procedure intervention. Some of the patient after Whipple, again, it depends on the type of Whipple, they have what we call it bile reflux, where bile comes back into the stomach easier because you lost your pylorus if you had that standard Whipple. And they have what we call it bile gastritis, and they will have sharp pain or, the gastritis pain that we just mentioned, different type of gastritis, but that's a type of a chemical gastritis due to continuous bile exposure to that area.
Yeah, so lots of things can go wrong after a major surgery like that. Definitely worth getting checked out. We had an email or a question just for you, Theresa. At what point is surgery required for repeated diverticulitis?
Oh, that's
maybe not an easy question.
Right. So it really depends.
Yeah.
It is something that is so individualized for each person, because there are risks, of course, associated with surgery, and it depends on how bad your diverticulitis is. Now, if you've had a major complication from diverticulitis, it's a quicker route to surgery, but still not a definitive route to surgery all of the time. A person can have an abscess from a microperforation and they still might not need surgery anymore. Previously, years ago, they would have had surgery. Also previously, if a person had more than 4 bouts of diverticulitis, they were recommended to have surgery. But now we recommend looking at how were those bouts. Were you able to take antibiotics? Did you have to miss work? Were you hospitalized? There's just a lot of things that go into it. So it's very individualized, and there's not a set number of how many bouts you need to have before you have surgery.
Yeah, not that simple. You know, it's something, diverticulitis, like this is kind of, we think of it as a simple thing, but so much has changed even in, I mean, even what I do in primary care, we do less antibiotics for mild diverticulitis anymore. So our knowledge changes. This is a really good example of that. Ali, we had an emailer ask about eosinophilic esophagitis. So can you give us just a glimpse at what that is? And their question is, what is the long-term outlook or prognosis for eosinophilic esophagitis?
So again, this is one of the new diseases that we have been noticing that is getting more popular, and we have been diagnosing a lot of these patients. The important thing is to differentiate between eosinophilic esophagitis in particular, or eosinophilic gastroenteritis, where it involves other segment of the GI tract. So the eosinophilic esophagitis, what we know about it, it's an allergy where you have a lot of eosinophils, a type of cells that attack the esophagus and cause inflammation. And that inflammation can become chronic, that can change the caliber, the texture, the mucosal covering of the esophagus. Most common presentation, young patient who comes in with food impaction, but a lot of patients, they come in with difficulty swallowing, sometimes ER visit for food impaction. We know so far that, diet has been the most common culprit in causing eosinophilic esophagitis, and based on allergy kind of algorithm or idea that certain food can cause this inflammation. So we usually, the best way is to do elemental diet, which is extremely difficult. So what we change is that we do 6 food elimination diet, and we get a little bit better that we can do 4 food elimination diet, or it depends on the patient, how they are willing to engage with you and do that elimination diet. The most common is egg, milk, and those are the 2 that we usually say that if you eat a lot of those 2 types of food, start with them, see how your response will be to that. Of course, acid reflux has been associated with worsening of those symptoms as well, and we treat eosinophilic esophagitis in certain patients with acid suppression medication for certain course. The target for me when I treat patients with eosinophilic esophagitis to have a control on their symptoms, which is very important, but also I want to control their histology. I want to make sure that their inflammation subsides, because if you leave them or you leave the inflammation uncontrolled or going, the patient will have stricture, they will have narrowing, they will have complication on the long run. And we got lucky enough that now we have FDA approved monoclonal antibodies and a biological agent for eosinophilic esophagitis resistant to PPI or topical steroids. So it's a spectrum again, and the patient should follow food elimination, acid suppression, topical steroids, and in most resistant severe cases, then we can use biological agent, and we have some of them with excellent response.
Yeah. So good treatment options. I feel like the handful of patients I have with this disease do eventually get good disease control, but it might take some time. Yeah. We had a caller wondering what kind of doctor they should go to if they are full after 3 or 4 bites. Might it have to do with the stomach or esophagus? So this is a consult I might send you across to you, Theresa. What can cause that early fullness or early full sensation?
So there's a number of things that can cause that early full sensation. It could be from the stomach. A person could have a gastroparesis type picture where they are just not moving food through their stomach, and so there's still food in there from previous meals, and after just 3 to 4 bites they're full. But we also want to evaluate for other things that can cause that, and one thing that we are concerned about is like a mass growing. And so when a person comes in with early satiety, we do need to evaluate to make sure that there's not something bad going on first, and then work through through the other possibilities.
Right. So a lot of those patients will probably get a scope
Yep,
with
a
you,
scope.
and then there's some imaging studies that might
Correct.
help. Yeah. Okay. Great. Well, while a food allergy and food intolerance have become more commonplace, sometimes those two can be confused for each other. Prairie Doc reporter Sam Schauer spoke with a registered dietitian to help define the difference.
Mary Aukes is a registered dietitian with Sanford Health, and she helps patients understand food intolerances.
Food intolerance would be something that that some people have a reaction to certain food items. It's not always going to be a reaction the first time. It may come after having multiple times, or depending on the amount of it.
Patients usually go to Aukes after getting tested by their allergist.
The dietitian would work on the diet end of it through the allergist doing those testing.
The biggest question she deals with is the difference between an allergy and an intolerance. She says an allergy will affect the immune system and sometimes cause anaphylactic shock, while an intolerance will not be very serious.
So you definitely, on a food allergy, you want to avoid that food at all costs because you have a food allergy. Or an intolerance would be something that potentially you could handle a little bit differently, working with a dietitian to help to see where you're going with that.
A good example of the difference is with the most common intolerance people think of, lactose.
Lactose intolerance, you're lacking this lactase enzyme that breaks down the lactose. So then you can do some different things with your diet, possibly to be able to still consume lactose. Where milk allergy would be an allergy to milk or other dairy products that is affected, again, by the immune system, and it will cause some type of a reaction in your body.
August says if someone is allergic or intolerant to a certain nutrient, the registered dietitian would help them figure out what supplements they should be eating to replace the allergen.
There could be a potential that you need to supplement with nutrients, micronutrients, macronutrient kind of options to get you that you're not able to consume. So you need to find supplementation.
And she concludes by saying if someone thinks they have an intolerance, they should check with their primary care physician before advancing to the next step.
It's important to know or to be tested and to find out if it's a true allergy or if it is just an intolerance.
Good segment. I feel like we hear a lot about food intolerances, and there probably is a lot of confusion about allergy intolerances and that kind of thing. Ali, when you have patients that you're trying to have do elimination diets, how long a trial do you ask them to do on each elimination diet for most symptoms?
So, for example, it depends again what we're dealing with. Like, for example, eosinophilic esophagitis, I usually tell them, like, you have to get a trial and trial and error. Mostly we follow clinically and see how their clinical symptoms improving. Once they improve clinically, then that will give me a hint. Okay, so you improved clinically. Let's try to introduce one diet at a certain time and give it like a week and see. If your symptoms recur, most probably that is the culprit and you need to stop it, and that's it. You're not going to come back to that diet again. And that's what we're talking about allergy. If we're talking about, for example, celiac disease, which is gluten sensitivity, you should be gluten-free forever, not even a touch of gluten. So it's a done deal once you confirm that diagnosis. If we're talking about intolerance, you got to tell the patient, you're someone who's not going to do well if you take lactose-containing products. You have two options. Either you take lactate supplement so you can digest lactose, or you stop taking lactose, or you just live with the symptoms if you really like what you eat. For example, someone doesn't want to give ice cream for whatever reason, and they don't want to take lactate, and they are okay with mild symptoms.
Yeah.
It's not harmful. It's just something that you get
something you want to know about yourself, right?
If someone comes with celiac, I will tell him no gluten.
Right.
And that you're going to harm yourself. There's a harm of taking gluten if you have celiac.
Yeah, different things. Good. Well, Theresa, we've had a couple questions about fiber specifically, which is like a common thing that we might try for GI symptoms. We had someone ask about what type of fiber is best. We had someone ask, is there a maximum amount of fiber someone should eat? So, like, what does fiber do in our GI tract? What can it help? And then maybe we'll talk about those questions.
So fiber is really good. It helps to regulate your bowels. You know, I utilize fiber a little bit differently depending on what the person is coming in for. Most of the time people are having constipation, and I recommend that they use a powder form of fiber so that they can also get a little bit more water in their diet as well. But it just helps to bring in some extra water into the stools and soften them. Now, if a person comes in with fecal incontinence, where they're not able to control their stools, now we want to thicken them up a little bit more. And so I use maybe a tablet form or a capsule form so that it has that extra ability to absorb the extra fluid that is in their stool already. Now, the maximum, I mean, there isn't really a maximum that a person can get. Most of us are way below the minimum that we should have. But when you're increasing the fiber in your diet, which is the more important part of it, you should do it slowly because there are some social consequences that come with it. And people a lot of times stop because they start getting cramping or they start passing more gas. And it is very good to have in your diet, but you just need to do it slowly.
Got it. That's good advice. Let's see. We had a caller. Let's do this one. I'm in my 70s, having some more GI problems. Had blood work showing maybe I have autoimmune disease, although rheumatology didn't come up with a diagnosis. The caller wonders, could celiac disease be the cause of what's causing that abnormal blood work, and any new treatment? So I guess talk about autoimmune disease of the bowel, Ali, a little bit. Hard to maybe be specific as an answer to this question, but.
I mean, I'll just kind of give you a kind of a spectrum again. I like when we do about GI diseases, and then there's a spectrum of those diseases. And an inflammatory bowel disease or autoimmune disease of the GI tract can be, again, on a long spectrum, affecting different parts of the GI tract. Celiac disease is basically affecting the first part of the small bowel or the duodenum, where you have blunting and abnormality because of gluten, where it will develop autoantibodies to attack those mucosa and that segment of the bowel. Now we have then microscopic colitis, which is specifically affecting the colon. And again, we don't really understand completely why it happened, but we relate it to certain medication. One of them is acid suppression medication or blood pressure medication or NSAIDs that cause, again, inflammatory cells like lymphocytes or collagen fiber to deposit underneath the mucosa in the colon and cause significant diarrhea. And then the autoimmune ulcerative colitis and Crohn's disease are other entities on the end of the spectrum that comes with a severe chronic debilitating disease that can affect the GI tract and with extraintestinal manifestation.
Yeah.
For example, if she asked about celiac disease in particular, I think the most important thing for celiac disease is to understand the diagnosis, to know how exactly you diagnose it. A blood test will give you a hint. So if you have a celiac serology that is positive, then the next step that you have to do an upper endoscopy with a standard protocol to take samples. And there's a way of taking those samples from the second, the first, and the bulb of the small bowel. And you send it for a pathologist who specializes in reading these pathology to give you the definite answer. And once you get that diagnosis, I usually send my primary care doc a list of things that you should do for your patient when they have celiac disease. And it's not just gluten-free diet. That's the first step. But they have to meet with a dietitian to counsel them. They have to have certain blood tests done to make sure that they are not, deficient in certain vitamins. And then, bone scan, immunization, and close follow-up with serology and endoscopy.
Yeah, good. So this person would benefit from seeing a gastroenterologist. That's for sure. So we are getting low on time, so we'll try to get through as many as we can. We had a caller ask, what are the causes of colon polyps, Theresa?
That is a multifactorial thing.
Yeah.
We don't know the exact cause of all colon polyps. There are some inflammatory polyps, so like a person who has some diverticulitis may develop an inflammatory polyp. There are precancerous polyps such as adenomas. Some can be familial, meaning that they run in the family, but there isn't a definitive cause. Now, it is suspected that there is some environmental factors that are going into it, as well as processed foods in our diet, things like that. And so not one cause, but just a lot of causes.
And plenty of genetic predisposition, like we've talked about as well, too, right? We had a Facebook viewer ask, what foods cause constipation? Are there foods that you avoid in chronic constipation, Ali?
So again, it goes back to having a balanced food. Usually, in general, the American food is more constipating because it's those fast food, unhealthy, lack of fiber, more carb, and those are more constipating. In general, I recommend my patients take a healthy, balanced food. Most people like Mediterranean or Middle Eastern kind of food because it's balanced. There is salad, there is soup, there is meat, there is balance of different type of food and texture. In general, I recommend 25 to 30 grams of fibers per day. We cannot get that through food, rarely. Even if you eat a lot of veggies and salad, I still think supplementing fibers will help with constipation. But, I think the balanced food is the key. Adding veggies and fruits, a key to avoid constipation in general.
Yeah, good. Let's see, we have a caller that asked, what are the risks of colonoscopy? You answer this all the time. Theresa, go ahead.
The main risks with colonoscopy is a risk of bleeding, as well as a risk of perforation or putting a hole in the colon. There are other risks associated with it too, but those are the two main ones. Sure. The risk of bleeding is about a 1% chance. You could have a little bit of blood in the stool afterwards, but as long as it's not significant, that's okay. The risk of perforation can range. There's a range for usually about 0.1 to 0.2% chance, and it can be microscopic too. So we may not know about it at the time of colonoscopy. So I do counsel patients to watch for symptoms afterwards and inform us if anything occurs.
But rare, the bad complications.
They are rare, yes.
Pretty darn rare. Okay, good. Let's see. We had a caller who had a stent in the hospital for a GI issue. So I guess let's assume that was a biliary stent. Physician told them a follow-up colonoscopy might be needed, but is scheduled several months out. Should she do anything to be seen sooner? Ali, I guess let's assume this was a biliary stent. What's typical as far as aftercare for the biliary stent? I guess let's answer that.
Yeah, that's where actually my subspecialty of doing interventional gastroenterology is to deal with stricture or malignancy or a stent need. And the stent can be anywhere, right? I can put a stent, endoluminal stent in the esophagus, small duodenum, or colon. We can put stents in the biliary system as well, or the pancreatic duct. Maybe this patient came in with a biliary, pathology like a stone or a cholangitis or an infection in the bile duct that requires a special procedure called ERCP, and they put a stent there. The problem sometimes, I will tell you, the story that I'm hearing here is that if you have a biliary pathology and they were advising her to do a colonoscopy, I think about primary sclerosing cholangitis, because patients with primary sclerosing cholangitis, it's an autoimmune disease affecting the bile duct. They might have inflammatory bowel disease or ulcerative colitis, and you want to make sure you do a colonoscopy to rule out that disease.
Sure.
So that's, I think, the connection here.
Yeah.
In primary sclerosing cholangitis, or PSC, they come with stricture that we need to treat and stent as a last resort. We try to dilate, stretch, and eventually, if we really need to, put a stent. But I think that's where the story is going.
Okay. Good. Let's see. We had a caller from Hot Springs. Theresa asked, what is Carafate or sucralfate? What is that medicine and what do you use it for?
So that medicine is a medicine that helps to regenerate the lining of the stomach when you have an erosive inflammation or even the chemical gastropathy. The top layer is eroded, and so that helps to regenerate it. It works differently than the acid-reducing medications do. And so we can use it in conjunction with it. It is a very difficult medication to take, though, because you cannot take it with other medications or with any food. And so
you have to take it 3 or 4 times a day in most cases. So yeah, it is challenging.
So it's different.
Yeah. Okay. Good. Let's see. We had a caller from Laverne inquiring if we could talk a little bit about exocrine pancreatic insufficiency. Can you touch on that, Dr. Ali? This might be another misunderstood topic in medicine.
Yeah. So exocrine, the pancreas has 2 parts, exocrine and endocrine, meaning that it produces enzymes to help digest food, and those enzymes go through the pancreatic duct into the small bowel and directly affect the food and digest the food. And then there is the endocrine part, which is, the hormone that goes to the blood and through the bloodstream can control your diabetes, your hunger, and the rest of, metabolism. So the exocrine part is, or the exocrine pancreatic insufficiency, when you have scarring of your pancreas to the point that the cells producing those enzymes are not producing them anymore, and you will have maldigestion and malabsorption. We see it in patients who develops chronic pancreatitis for multiple reasons, either from chronic alcohol and smoking use to the point that they really destroy their pancreas or scar their pancreas, or in patients who had inherited diseases or inherited pancreatitis from their families at a young age, and or in patients who develop pancreatic cancer, where the cancer overtake the pancreas and you will become insufficient. Yeah. Now we have been seeing the same way that we see, non-alcoholic fatty liver disease. We're actually noticing more non-alcoholic fatty pancreas disease, where patients have fatty pancreas and they will develop pancreatic insufficiency. Yeah. The treatment of that is replacing it. You give them the enzymes. The challenges with this, and I think most patients will know that, it's pretty expensive, unfortunately, and the insurance company with the coverage still, it's very expensive to cover those, replacement enzymes.
Yeah. Generally speaking, you have to have had an injury to your pancreas of some sort to have this disorder, though. Doesn't just happen. Yeah.
Yes.
Okay, good. We got 1 minute left. We'll do some real short answers. We had a caller from Rapid City ask what can cause acute constipation. That might be more worrisome, Theresa. Yeah.
Correct.
Yeah.
So if you have an acute change in your bowel habits, such as constipation, then we worry that there may be something obstructing.
Right.
It could also be benign things going on as well. And so, but it warrants looking into it. Absolutely.
Yeah. Good. Yeah, worth being seen. What age should we get our first colonoscopy, to be brief, Ali?
45.
45.
45 for average risk individuals, and I really encourage everyone at 45, average risk, no family history, no genetics, just average risk.
Yeah.
Go do your colonoscopy. Do a screening test. I don't want to say colonoscopy. Do a screening test for colon cancer, just to be politically correct.
Excellent. The winner of our prize tonight is a Facebook viewer named Annie. Thank you, Annie, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Searching for trusted medical information or looking for a doctor for your medical needs? Head to the Prairie Doc YouTube channel today to access previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
A common lament I hear from my patients as they try to discuss a real concern they have about their body. I'm sorry, this is so disgusting. Their cheeks burn with shame as they tell me how their bowels have betrayed them. No matter what the issue is, so many of my patients are mortified discussing their diarrhea, constipation, fecal incontinence. My response always is, you can't gross me out. We talk about poop every day in this clinic. Plenty of things can go wrong in the gastrointestinal tract, and even minor issues can be really disruptive in a person's life. Certain features of bowel dysfunction, like blood in the stool, abdominal pain, and weight loss, might signal more urgency to get a problem diagnosed and fixed. We certainly don't want to miss things like tumors, ulcers, inflammatory bowel disease, and diseases that might affect absorption of nutrients. Oftentimes, none of those red flags are present, but a patient's gastrointestinal symptoms are affecting their ability to function at work or socially. In cases when we either have ruled out or have low suspicion for something bad, we can still offer plenty to help with these symptoms. Sometimes that might mean trials of elimination of food types, dietary changes, addition of fiber, or other medications. GI symptoms might be a side effect of another medication. We frequently have to do some trial and error to find the right combination of things that improve an individual's function, but usually we can do so. In some cases, consulting with gut specialists, dietitians, and even physical therapists can be very helpful. My point here is this: if you are having gut symptoms that are worrying you or disrupting your day-to-day life, let's talk about it. Whatever discomfort you have discussing it, I promise, is not shared by your primary care provider or friendly gastroenterologist. We want to help you get answers. And even if there is not a simple diagnosis or fix to the problem, we want to help you be more comfortable leaving the house without worrying about what your gut will do. So please, don't let feeling grossed out keep you from asking the question. Thank you to our guests, Dr. Oey-Trudeau and Dr. Zakaria, for volunteering their time to help us learn more about the future of GI issues. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us live every Wednesday morning at 9:30 on KBRK Brookings, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
For most people, our home is our safe haven, yet sometimes our home can also pose a risk to our health. Stay healthy out there. Next time, On Call with the Prairie Doc.
Hello, my name is Dave Heinck, and I've been a board member at Healing Words Foundation for the last 9 years. Well, my background goes all the way back to DeSmet, South Dakota, where Rick Holm and I were childhood friends. We're at USD together, and we've managed to stay close friends for our entire lives. And I spent the bulk of my career with Weyerhaeuser Company in the Pacific Northwest, and I led their production forestry research group. I also spent time on the faculties of Auburn, Virginia Tech, Purdue, and affiliate faculty positions at the University of Washington, the University of Idaho. And in retirement, I've spent most of my time in the nonprofit world in board service. When Rick and Joni were putting the foundation together several years ago, Rick would call and ask a question or two, and I usually had the answer, or at least where he could go. And so eventually, he and Joni invited me to be a member of the Healing Words Foundation board, and that's how it happened. The foundation and the Prairie Doc media production is really committed to truthful, timely, tested medical information. And there's a lot of information out there now that's either half truth or no truth. And of course, being a scientist by profession, we're always seekers of truth, understanding full well that the truth can change with additional research. Every dollar that's pledged or given to Healing Words Foundation unleashes an army of volunteers. The foundation and the Prairie Doc Media puts out really good stuff, very useful things. So there's a high return on the investment to invest in the Prairie Doc. For more information or to donate, head to www.prairiedoc.org or send your donations to Post Office Box 752, Brookings, South Dakota 57006. Thank you for support.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions:
Brookings Health System,
Ophthalmology Limited,
South Dakota Academy of Family Physicians,
Avera Heart Hospital,
First Bank and Trust,
Dakota Allergy and Asthma,
Vance Thompson Vision,
Monument Health,
Black Hills Medical Society,
Brookings Madison Flandre District Medical Society,
Pierre District Medical Society,
Sioux Falls District Medical Society,
Yankton District Medical Society,
Orthopedic Institute,
Lake Ponset Sailing Academy,
Aberdeen Asthma and Allergy,
Dakota Bank,
South Dakota American College of Physicians,
and Swiftel Communication.